already. And so the Pathfinder 2, for the first 25,000, which they have 12-month data on, they found the overall sensitivity to be 40% for this test, which at, by looking at it, that's overall sensitivity for all the sites. Doesn't seem super high, but when we start looking at sites, the technology kind of gives us insight into why we might see differences between some sites and others. But one thing to really point at is the 12 cancers responsible for the majority of US deaths, the sensitivity is about 74%. And then for the 6 most aggressive cancers with a low 5-year survival, about 72%. And this other chart says that if you exempt breast and prostate, the number goes up significantly. Thankfully, we already have screening tools for breast and prostate, but these multi-cancer early detection tests just aren't that good at picking up those sites. And so as part of the Circulating Cell-Free Genome Atlas validation study, what they ended up doing was identifying or providing sensitivities for each cancer site. The ones I want to pick on here are the ovary pancreas story. The sensitivity there is over 80%. And this is a very valuable sensitivity given the fact that our imaging just can't compare to these kinds of numbers. Particularly in the CHARM2 wants a hereditary risk because people are elevated risk for so many different types of cancers, but just this as a standalone, if someone's indication is to look for ovarian and pancreatic, the multi-cancer early detection test is an option. But if people are interested in the breast prostate story, multi-cancer early detection test sensitivities are actually quite low. And one of the reasons for this is having to do with the staging with which the cancers are identified. So a big chunk of these breast and prostate cancers that were identified were actually later staged. However, most breast and prostate cancers are early stage. And so one of the reasons why the values might be so low is that it's picking up the kind of more aggressive breast and prostate cancers here. But most prostate cancers, for example, are just not that aggressive, and so might be encapsulated, might not shed enough cell-free DNA, might not be picked up by a test like this. So if we do go into the same sensitivity, but focus on just stage 1 and stage 2 disease, then we see another interesting story. And so the ovary pancreas, we have about a 60% of the cancers identified are stage 1 and stage 2. For the head and neck and the plasma cell neoplasm, where we expect to see higher volumes, we see lots of stage 1 and 2 disease. And then for the prostate and breast story, the minority of cancers identified are stage 1 and stage 2. This is the data from the Pathfinder study, and there were 35 cancers identified in a cohort of 6,662. 35. And 6 of those were actually recurrent metastases. That was 5 of those were breast, and 1 of them was a lymphoma. But what we see here is that in a cohort of 6,000 individuals, we're not seeing really high rates of cancer. There's 1 pancreatic cancer that was identified in that cohort, 1 ovarian, a few oropharyngeal cancers. And so even if we do this, wide screening effort, we're not going to get a high volume of people who have a clinically detected cancer. I'm going to switch the gears here over to Dr. Poirier.
Okay, so love all the technology, well beyond my level of expertise to understand all that methylation and how this test was designed. But what I do understand is, okay, how do I apply this technology, especially on a population-based studies? Does this make sense to use in a family doctor's office to start screening my patients or my clients? And so the data here, I'll switch over to just the Pathfinder 2, which is the column on the right. The difference between the two is with the Pathfinder 1 study, they got certain results, and they were trying to fine-tune the positive predictive value, and so had to decrease some of that sensitivity in order to be able to achieve that. So that's why we can see a higher positive predictive value over on the right-hand side, third line down at 61.6%. So that test to me is good in that sense. And a negative predictive value, though no test can fully eliminate any cancers, including the current cancer screening test that we use. We can't say for 100% that they don't have cancer there. It's either it looks negative or it's positive. 99.1% chance is not a bad statistics for negative predictive value. So cancer signal detection is about 1% of the people that we're screening, and so again, like Justin had said, not high numbers currently with these population. Now the NHS study is going to be 140,000 with half of them in the actual testing arm, so 70,000. So we'll see if that percentage actually stays at that in and around that 1% value there. And what I like about this is like we're needing to numbers needed to screen to catch a cancer at 174 people to catch a cancer with the current numbers at Pathfinder that we have is reassuring that I'm not having to screen overly to catch a cancer. So it actually seems worth doing with this type of number for me as a family doctor. Especially when we look at the values of number needed to treat, number needed to screen. This falls in line very well with our current screening tools at this point. And so the specificity, great here again, high specificity. So that's where the sensitivity takes a hit, but I'd rather be more specific and have a higher positive predictive value at this point. So when someone gets a test done and it comes back as a negative test, this is the exact correspondence that they get sent to them. So as you can see, no cancer signal detected, and then it provides about 7 pages worth of detail of the test, including that though it says no cancer signal detected, it cannot rule out cancer 100%, as we saw 99.1% negative predictive value there. So just to take you through that, just to see what details these guys have put out for this test and result. So we had a case, so we've been doing this test since October 1st.
20th.
Yeah. Oh, October 20th.
Yeah.
Already. Okay. So October 20th. And so right now our detection, I guess, is kind of in par with what Gallery said it would be. And we have had one positive result. Now, we had an 85-year-old female, completely asymptomatic. She just came in for the annual health assessments that we provide and decided to do this test as an add-on. Quite healthy otherwise, and still very independent on her own with a great quality of life. And so the only thing we started finding is that there was a big jump in her hemoglobin A1C, 6.5, down from 5.9. Her abdominal ultrasound that we did here at site, and the pancreas looked completely normal during the abdominal screen. She did complete the Gallery tests, and then the result came back actually for pancreatic cancer signal detected. And so when we receive a positive signal, this is what we get, or sorry, this is what it looks like. So cancer signal detected, and you can see down the left-hand corner, it'll tell you the most likely culprit site. And so it allows us to then go through an algorithm of the best workup for this type of test. I'm just going to skip down one slide. So this slide here is what Grail will send us and say, hey, this is what we recommend for a workup. And this was specifically for the pancreatic positive screen signal. It had lab work recommended there on the left, and imaging recommended there as well. And then fortunately, this test has been out since 2020 in the United States. The Mayo Clinic has been using it, and they've been able to come up with their own algorithm. Depending on which site-specific or site of origin is detected, they've provided an algorithm there as to what they do from a diagnostic testing perspective on the right-hand side. So we decided to follow as closely as we could in this instance. So the blood work came back with the CA19-9 at 1,361, and CA was at 13.4. We referred for CT chest, abdo, and pelvis at CanMax, which is a privately funded imaging center in Buffalo. Buffalo? Yeah. And so she self-paid to get this test done. And so we're able to complete those tests. And then that test came back with a 4.1 centimeter pancreatic tail mass, again, that we didn't catch on the ultrasound. And there was a nodule in the right lower lobe. However, that nodule was pre-existing, hadn't changed. And so currently this patient has been referred to the Wallace McCain Center for Pancreatic Cancer and awaiting further assessment and workup from that aspect of things. So when is she meeting? Oh, she just met last week with the oncologist on November 27th. So obviously we haven't had any of the reports back yet from that consultation. So, okay. This is where we want to kind of open up the floor for questions, comments, anything that you have to make this as interactive as possible.
Dr. Vesperini, I love your icon.
Oh, I didn't know my. Oh, that's my cartoon version of me. Good talk. I like your presentation of the data in regards to number to screen and treat. How do you think this compares to, for example, PSA? We've got legislations around the world that are starting to get rid of it now. If you look at most of the trials with PSA screening, you need to essentially screen 250 people to save a life. How many lives do you think this is going to save if you need to screen 174 just to find a cancer, when the cancer may be pancreatic, when you're not going to save their life anyways? Do you think it's comparable? We need to be able to count our patients for that.
Yeah, for sure. And this is what I tell my clients currently is that theoretically, this makes sense, especially, the earlier stages that we can catch cancers. Obviously, you can catch this cancer in stage 1 and 2. Survival rates are around 89%. Stage 3 and 4, that can drop to 20% or less. And so theoretically, it makes sense to improve mortality rates in that respect. The NHS study that's going to be published in 2026 will shed even more light on that, since it was a 3-year kind of follow-up to see survival rates at the 3-year mark. And so that data is still pending. But right now, our rates of detection are horrendous in some of these cancers. And so the mortality rates are horrendous as well. So I can only theorize that, catching these cancers earlier will improve the outcomes at this point. But that's all I can comment on at this time. Justin. Great question, though. I asked myself that question too. Is this actually going to make a difference?
Yeah, I think it certainly will make some people sleep better at night, because there's a 1% detection rate, because the vast majority of people that we're testing don't have cancer.
Mm-hmm.
But as Justin, I think I came in late, so maybe alluded to, the question is whether in higher risk populations, this actually may be a test that actually will have a higher pickup rate. But the average person on the street, the question is it worth spending $2,000, whatever it costs to sleep better at night?
Mm-hmm. Yeah, and that's an individual decision, right? Would you like to? And like I tell people, the only thing I can do is screen early. And so, I feel comfortable with the evidence this is provided. It's at least a valid test. And yes, I agree. We need to see what the data shows at 5-year survival rates and on, and that data should be coming soon within the next couple of years as well.
I should note for these emails at Sunnybrook, it's your first name dot last name, but at MedCat it's not.
Yeah, it is.
Is it?
Yeah,
Oh, okay.
that's the right email.
Oh, good. Okay.
Yeah. Oh no,
Um,
it's not dot. It's complete.
it's just complete. Yeah.
Yeah.
I'll change that there. And then we have a few other supplemental slides as well that, oh, yeah, it won't let me. Anyway, you can note that.
Yeah.
I think there's a question in the chat.
Oh, where's the chat?
I'll read it for you. Are there any particular reasons why detection levels are so low for certain cancers but high for others, and what type of NGS is being used?
Yeah. So good question. So NGS is not being used. It's going to be the methylation patterns that are identified on this. And so the theory for why we have different sensitivities, it's a really good slide. One thing I like about the gallery is they're just not, the data is what it is, and it's on every result. Some people will come in and say, hey, listen, I'm really worried about my, family history of breast cancer. And they say, well, I want to do this test for that reason. And I say, well, the sensitivity for breast cancer is not super high. And one of the big tenets with this test is that this is meant to, it's designed to supplement screening, not replace it in any way. And so to answer the question about the differences in detection rates or sensitivity, has to do with the mechanism of cell-free DNA in cancer. And so you have some of these really highly vasculated cancers or cancers that are known to shed more, such as liver, for example, and then the thought is pancreas and ovary. So it might just be that they're so well vasculated or the cancer is interacting with the bloodstream at a higher rate than some of the more encapsulated cancers, like a DCIS, for example, or a low-grade prostate cancer. Thyroid, there's a zero detection rate, and so very encapsulated. So probably the biology of the cancer is meaningful in the sensitivity. There is a question about looking at urine samples to help with some of the more genitourinary cancers to say, could there be a signal that's there to increase bladder or kidney or prostate. But PSA is a pretty good screening test. Breast cancer, mammogram is a pretty good screening test. And so luckily, some of the sites that it has a bad sensitivity for, we already have okay screening for.
Another question that's on there that's kind of similar, but maybe you can expand upon is, can you comment on colon cancer versus, for example, polyps or uterine cancer, fibroids, or any other kind of either precancerous or in situ disease?
Yeah, it's a really good question. So even for the pancreas story, IPMN is high in most people who are like 70 or older, right? They may have an IPMN. Or the risk for having it is there. And so could that influence the signal? Maybe that might be what we're seeing when we get a false positive result. So the protocol here is that if there is a positive result that's identified, 60% of the time, cancer is identified, 40%, it's a false positive, and it could be that it's picking up IBS. Maybe there is a polyp that's there, and that's the explanation for the false positive, or it's just a flaw in the technology, or it's an early stage cancer that just can't be picked up on imaging.
And I would say, like, we don't use it for those types of cancers, right? Like, I tell my clients, especially, we're not replacing colonoscopies or the approved FIT testing. We're not replacing mammography. We're not replacing cervical cancer screening. This is definitely in addition to. And what I'm most excited about is those 12 most aggressive cancers that I have zero screening tools for. Zero at this point. And so that's why I see it as a game changer from my end of things as a family doctor to screen for these types of cancers. And everybody, I'm sure, has known someone with pancreatic cancer and what that diagnosis is and the likelihood of us catching it early enough to make a difference. At least as a family doctor, in my experience, has been dismal. And so this offers some hope for these types of cancers, though not very common. It's still a way that we can maybe approach this in a way that actually has a positive impact for our patients.
But do you see this as like it's such an expensive test? It's a lot. They can't longitudinally. You can do mammograms every year. You can do PSAs every year. You can do colonoscopies as much as needed. But I don't know. I mean, is this technology going to change so that it can be like that? But because you're not going to pony up $2,000 a year, you got a baseline capture in time. But
yeah. So it depends on the person, right? People will prioritize what they want to spend their money on. Much like if someone goes to a cheap inclusive or an expensive all-inclusive, it depends what they want to spend their money on, and this may be worth it for them. And I will tell you this, that the people I deal with are more motivated from a health perspective than in my general practice that I had previously. So very good question there. As the technology is patented or the patent falls off, these tests may become more and more reasonable in pricing. Obviously, anytime anything's new, they want to profit off of it for sure. This test is about 950 US at cost, and so put the exchange rate on that, $1,300 to $1,400 Canadian. And I tell people, well, what do you spend maintenance on your car for, right? And it all depends. That's an individualized patient conversation to have from that aspect of things. So hopefully this test becomes more affordable, because as a family doctor, I'd love to screen everybody that I can, and I don't want it to be cost prohibitive. But given what we're being given, this is all I can deal with at this time. And I want to make the best impact with what I currently have technology-wise at this time. Any other questions? So just kind of a comment and me, from my end of things is, I know I don't want to put any more work on my specialists, and that's why, like, as a family doctor, I take the onus on working this up as far as a family doctor can work this up. And then once we have a positive diagnosis with the additional workup, that's when we would send to the oncologist, like we did for our possible pancreatic cancer client. And another interesting stat is that only 0.6% underwent invasive biopsies to work up. So very low physical testing done outside of imaging. Most of the cancers were able to get diagnosed via imaging, and then obviously the oncologist can biopsy and make and do whatever it is that you guys do to make things better for these clients. But yeah, I don't see this as an onus on our oncologists from the sense of a workup point of view. I think that still falls to us, and I feel comfortable doing that, and I feel like I'm doing a service doing that, and then going from there.
Which I think is like an interesting point in that regard, where people will be getting these results back. The volumes of cancer signal detected results we anticipate to be very low, but we want to do have this test done in the most responsible way that we can. And so we're always interested in making connections with oncologists who would be willing to see a case where there's someone who has a cancer signal detected, who has a lesion identified on imaging. We're always looking for who a good provider is to send individuals. Because we're going to get low volumes, we anticipate, in this year, having maybe 10 people who have a cancer signal that's detected. And then when we publish on that, we expect that there's going to be really low volumes. And so, we might just have a trickling of patients who are seen, but that's enough for us to want to report what we do. And so if anybody's interested in being involved and being one of the preferred providers that we can send people to, we're all ears and we're happy to open the doors to that type of a collaboration. There's another question. For cancers with inherently low cDNA, circulating tumor DNA shedding, such as localized thyroid, kidney, DCIS, yeah, what technical or biological strategies are being explored to improve detection? So one of them was looking at different sites. So for example, urine for the kidney story, perhaps. But it might be further down the line, looking at technology to miss those. I think one of the missing gaps in our screening is for the ovarian and pancreatic cancers, those hard to detect and really aggressive ones. And so, the thyroid, kidney, and DCIS tend to be the cancers that we're not overly concerned with because they are easier to treat and easier to detect through other modalities. And so I think eventually there'll be people who do that, or maybe other companies that might specialize in that. But at this point in time, the bread and butter of this test is going to be those liver, ovary, pancreas cancers. The challenge is these HPV-related cancers, the lymphomas. The workup for that's going to be a little bit a little worried about that, but we'll cross that road when we get there. And it's kind of a learning process. We have Mayo Clinic to guide us. We have a gallery to guide us as well. And so just happy that this test is coming, and it's just a matter of who's going to be able to provide it and execute this test. And so the purpose of this is to let you know that this is coming down the pipeline and it's infiltrating. It's becoming part of the experience of some Canadians. And so don't want the first time you see something like this to be in someone's a record by chance, hoping that this can give you some kind of insight as to what might be coming up, and so that a gallery result is the second time you see it from the patient.
Any other questions?
I hope lunch arrived. It looked like it was coming late.
Oh,
Yeah, it was really great. Thanks, guys. I mean, it's helpful. It's helpful for us. I mean, not including the genetics stuff that Justin and I do, I get asked almost every clinic now about it. And on Friday we had one, and it was one of my testicular cancer patients. I had to call Justin after clinic because he's asking me, should I do this test? And I just having those numbers, I think, are important in our head, because I think that's what people need to know and decide if what's worth it for them, just based on the cost of the test itself, right?
mm-hmm.
It was really good.
And we had that Aristotle case. There's other multi-cancer early detection tests that are out there. But Danny, you had that one patient who had that positive, cancer signal for prostate.
Yeah.
And the journey he kind of went down.
Yeah, and that's the important part of what you guys discussed today, is the positive predictive value and obviously the core of the false positive rate, which I think we need to be able to manage people with. But I think it's all, it's available, so we have to make sure people know about it, and this is what they're getting into. So this was very helpful for me.
Thank you. Yeah, the goal is to learn from experiences like that and say, don't say that. Know that if someone's doing a test like this, they're having a detailed conversations. They're not just being let loose into the world. That we're trying to do this in the most responsible way that we can, and I think that we're doing a really good job. Thank you very much, Danny. I really appreciate you navigating the questions and helping us on Sunnybrook's end.
Thank you so much, guys. Seriously.